For this presentation, we'll be looking at heart failure in a much of a simplified version. So when we look at heart failure, it's really an abnormal condition that is involving impaired cardiac pumping or filling. But really what it is the pump is failing. So when we look at the heart, the primary role or the function of the heart, it works as a pump. And so when this condition of heart failure exists, it means that the heart is unable to eject adequate amount of blood or adequate cardiac output that will meet the metabolic needs of the body. Heart failure can be associated with many different types of cardiovascular diseases. And so some of the most common ones are primary or essential hypertension, coronary artery disease, primarily looking at a myocardial infarction or an MI, or commonly known as a heart attack. So there's some things that can characterize heart failure, and one of the things that's characterized by is ventricular dysfunction. So the ventricles are not working or pumping as they should, ultimately reducing that cardiac output. And so once cardiac output is reduced, exercise tolerance in the individual also becomes reduced. Over time, heart failure can diminish the quality of life and also result in a shortened life expectancy in patients. Just for a little bit of statistics, heart failure has been found to affect 1 in 5 people over the age of 40, with coronary artery and hypertension being responsible etiologies for up to 47.7% and 26% of clients respectively. So heart failure is not a disease but a syndrome, and really what that means is it is a set of medical signs and symptoms that are correlated with each other and reflective of a particular disease or disorder. As mentioned before, heart failure is associated with long-standing essential or primary hypertension, coronary artery disease, and a myocardial infarction. So when we look at the causes of heart failure, it can be divided really in two groups: primary factors and precipitating factors. And so when classifying heart failure, that can be classified as systolic or diastolic or dysfunction. Now we're not going to go into too much of systolic versus diastolic, but rather classifying it based on right versus left or biventricular failure. When we look at primary, these are more common causes. So as mentioned before, hypertension, uncontrolled or long-standing primary essential hypertension, and coronary artery disease. Precipitating factors are things that can often increase the workload of the ventricles and over time result in a decompensated condition and reduced myocardial functioning. So primary risk factors is looking at coronary artery disease, long-standing primary or essential hypertension, particularly if it's not managed or controlled properly, whereas contributing factors would be things like diabetes, tobacco, obesity, arrhythmias, high cholesterol, etc. So when we ask ourselves what causes a ventricle to fail, regardless if we're looking at the right ventricle or the left ventricle, we can kind of categorize those into broad categories of things that will cause a right ventricle to hypertrophy, weaken, and fail over time. And so one of the very first things would be an increase in workload or an increase in afterload. And as soon as we think about increase in afterload, we're thinking resistance. So think about where, for example, the left ventricle is pumping into. The left ventricle is pumping blood into the aorta and then to the body. It's pumping into arteries and arterioles. So then we want to ask ourselves, what type of resistance can be faced by that left ventricle? And so commonly when we look at increased afterload, we're looking at vasoconstriction of vessels. The second reason why a ventricle would fail is because of damage. And so, for example, when you think about something like coronary artery disease, particularly myocardial infarction, the heart or the ventricle decreases because of ischemia and necrosis. It loses its contractility. And because the contraction is decreased, it means that the volume that's going to be ejected is also going to be decreased. And then third is valve defects. So think about again, where is the blood going from the ventricles? It's going into the aorta, for example, from the left, but we have a valve right here, the aortic valve. And so if that aortic valve becomes stenosed, for example, where it becomes hardened and very difficult to open, in order for the left ventricle to eject the blood, it means that it's causing increased resistance to that left ventricle, and therefore over time that ventricle will start to hypertrophy, and as it hypertrophy, it's going to fail. So the way you want to think about it, what will cause a ventricle to fail? The ventricle enlarges or it hypertrophies, it loses its contractility, and it will fail. And so anytime it's faced with increased workload or afterload, there is a damage to that myocardium or that ventricle, or because of, again, increased resistance from valvular defects, that will cause the ventricle to hypertrophy and it will fail. So we're focusing here on the left side, but you're also wanting to start to think about the right ventricle. And so we know that the right ventricle is pumping blood to the lungs. So start to think about what type of resistance can occur in the lungs and which valve is between the right ventricle and the lungs that can eventually become stenosed, hardened, or defective, increasing that workload on that right ventricle. So the first one we'll look at is left-sided heart failure. So when we go back and I think again, what would make a ventricle fail? Increased resistance. And so we know that the left ventricle is pumping blood into arteries and arterioles. So if there is any pathology that would cause vasoconstriction of these arteries, it means that there is increased resistance. And so increased resistance or afterload means that this ventricle is going to start to hypertrophy and fail. So thinking about the etiology, I'm going back to primary causes. The first thing that should come to mind is long-standing hypertension or essential hypertension. The other reason is damage, so coronary artery disease or MI, which will cause that ventricle to lose its contractility. And then you think about valvular diseases, so aortic stenosis. So we know once these conditions are faced, this ventricle is going to start to hypertrophy, weaken, and fail. So ultimately, it's not able to eject blood. So the ejection fraction or the cardiac output that is coming out is going to start to decrease, which therefore means that this blood is now going to start to accumulate in the ventricle. And as the blood is accumulating in the ventricle, it's going to force the mitral valve to be open, and blood is now going to enter into the left atrium. And blood is then going to return to where it come from, which is the lungs. So here we're going to have blood backing up into the pulmonary system. And so we're going to have fluid is going to start to accumulate in the lungs, resulting in pulmonary edema, which results in congestion. So as that blood is backing up, remember it's backing up with hydrostatic pressure. And so one of the manifestations that we'll see, or clinical manifestations or symptoms, if we now look at some of our symptoms that we'll see with left-sided heart failure, one of the first thing is dyspnea, or shortness of breath, as most of us know it as. So the patient will experience trouble breathing. The other thing that they will experience is orthopnea. And what is orthopnea? Really where you're experiencing difficulty breathing when you're lying down. And really it's all because of this pulmonary congestion. So difficulty breathing in a supine position. Also, what can occur is something referred to as paroxysmal nocturnal dyspnea. So if you think about this for a second, so paroxysmal Paroxysmal means it's happening suddenly. Nocturnal, it's happening at night. Dyspnea is shortness of breath. So you think about it for a second. When you're lying down, you're going to have increased venous return back to the heart. So it means that we're having increased blood returning from the inferior vena cava back to the right side of the heart. That's then going to go to the right ventricle. It's going to go through the pulmonary artery and it's going to go to the lungs. Once the blood gets there, it therefore means that we're now going to have, as these patients are lying down, they're going to have a large amount of blood that is returning. So increased return to the left side of the heart. And because the left side or the left ventricle is weak, that sudden gush of blood that is returning now to the left side of the heart is what is causing that sudden awakening from their sleep with shortness of breath. So when we say paroxysmal nocturnal dyspnea, that's shortness of breath. They can also experience pink, frothy sputum. And so why is this occurring? If we were to expand this alveoli a bit and take a look at the alveoli in a little bit more depth, we know that this alveoli is surrounded by pulmonary capillaries. And so when we start to accumulate fluid inside of here because of the pulmonary edema or the congestion, that can then result in this capillary bursting. And so once the capillaries start to burst, what we can end up with is pink, frothy sputum. Also, because of the water in the lungs or the fluid that's in the lungs, when you auscultate, that will come across as crackles or rales. So just to recap, when we think about the left side of the heart and left-sided heart failure, symptoms that is involving the lungs, we think left-sided. Shortness of breath or dyspnea. Orthopnea, which is difficulty breathing in the supine position. Paroxysmal nocturnal dyspnea, sudden awakening at night with shortness of breath. And again, that's simply because you are sleeping, your legs are now elevated. We're seeing an increased return, venous return to the right side, which then goes to the lung and therefore means increased return to the left side and is causing that sudden gush of blood back into the pulmonary system, causing the patient to wake up suddenly with shortness of breath. And because of the excess fluid in the alveoli, we can result in pulmonary capillaries starting to rupture and bleeding into those alveoli, creating pink frothy sputum, as well as if you auscultate the lungs, you're going to hear crackles or rales. So just to recap from the previous slide, we're going to look at left-sided heart failure as a synopsis. So when we look at etiology, again, primary, not contributing causes, left-sided heart failure most commonly is as a result of the left ventricle dysfunction. And what's causing that left ventricular dysfunction could be an MI or a heart attack, causing the ventricle to lose its contractility. Hypertension, long-standing primary or essential hypertension because of we know that it is idiopathic with arterial vasoconstriction, which will increase the afterload on that ventricle. Valve disease, which is, for example, aortic stenosis. When we look at symptoms, symptoms is you want to first think about where is the blood coming from? It's coming from the lung. So if that left ventricle is failing, blood is now going to back up to where it came from initially. And so symptoms really is because of the blood backing up from the left ventricle into the left atria, into the pulmonary veins, into the lungs. And once it get into the lungs, we're going to have some symptoms such as pulmonary edema or congestion, orthopnea, unable to lie flat in the supine position, paroxysmal nocturnal dyspnea, for short PND, and we know that's because patient is in supine. We have increase in venous return to the right side of the heart with large amounts of blood going to the lungs, and then that blood all going to the left ventricle and causing the left side to then suddenly send blood back to the lungs because of backup and patient experiencing shortness of breath. Because of the pulmonary edema and congestion, you're going to hear crackles or rales on auscultation. And because of that fluid in the alveoli and high hydrostatic pressure, capillaries will burst, resulting in a pink, frothy sputum. So now looking at the right side of the heart failing or right ventricular failure, what we're now going to look at is, or just reflecting back on what would make a ventricle fail. Increased workload or resistance on that ventricle, damage to the ventricle. And so when we focus on the right side and we look at some of the etiology of the right side of the heart failure, the very first thing that comes to mind, or what would be the most common, is left-sided heart failure. So when the left side of the heart fails, if you recall, blood is going to back up from the left side into the lungs. And so as blood is backing up into the lungs from the left side, what we're now seeing is, if you were to have the alveoli, and you remember there is going to be fluid inside of the alveoli, what that does is it increases pressure in the pulmonary artery. And this increased pressure in the pulmonary artery is then going to cause increased resistance on this right ventricle, causing it to hypertrophy and fail over time. Second one is lung diseases. So another reason for the right ventricle to fail is lung diseases, and a very common one is COPD. So with COPD, what we know in the alveoli, because of damage, there is decreased oxygen. And ultimately, what we do end up with is the pulmonary capillaries starts to vasoconstrict, causing pulmonary hypertension. Because of this resistance in the lung, as the right ventricle is trying to send blood to the lung, it's meeting with a lot of resistance from these vasoconstricted pulmonary arteries. In other words, it's faced with increased afterload or resistance. Then don't forget also what we can experience is MI, or a myocardial infarction of the right ventricle, which means it's going to decrease the contractility and eventually leading to right ventricular failure. And also, this is not immune to valvular diseases as well. So, as part of the damage that can occur to the right ventricle, could also be because of valvular disease. And if you think about which valve, the right ventricle needs to open this valve right here, the pulmonic valve, to send blood to the lungs. So if that valve becomes stenosed, hardened, or defective, then again, it's causing resistance on that right ventricle. So just to recap, when you think about etiology, I'm going to put an asterisk. The most common cause of right ventricular failure is because of the left side of the heart is failing already. Then we also have lung diseases such as COPD, which is going to cause pulmonary hypertension from vasoconstriction of the pulmonary vessels. MI, or coronary artery disease, involving the right ventricle will cause a decrease in contractility and hence failure of that right ventricle. And valve diseases resulting in, so think about the pulmonic valve, if it becomes stenosed, also increasing resistance. So when we visit these etiology, again, these are some primary causes or primary factors resulting in hypertrophy and weakens the right ventricle, causing it to fail over time. So now we know that the right ventricle will fail. So let's say, for example, your patient has left-sided heart failure, and that's going to cause the right ventricle to fail, or your patient has long-standing COPD with pulmonary hypertension causing the right ventricle to fail. So what symptoms, if a patient walk in and we don't have an echocardiogram or any other diagnostics, just using our assessment skills, how can we know whether this is the right or left ventricle that is failing? And so now we're going to be looking at clinical manifestation or symptoms. And so one of the first things that we want to consider, where is the blood coming from to the right side of the heart? And blood is coming from the systems via the IVC, or inferior vena cava. Blood is coming from the head and neck via the superior vena cava. So when this right ventricle starts to hypertrophy and fail over time, blood is now going to accumulate. It is going to force the tricuspid valve to open in the opposite direction. It'll then back up into the right atria, and this blood is then going to back up into the SVC and the IVC. So the inferior vena cava and the superior vena cava. If blood is backing up into the superior vena cava, what you're going to see clinically in the patient is something referred to as jugular venous distension, or JVD. The inferior vena cava is draining the system. So one of the very first signs that you'll see because of the backup, remember when blood backs up, it's backing up with increase in hydrostatic pressure or push pressure. So we're going to start to see fluid being pushed out of the venous system into the interstitial space, resulting in edema or peripheral edema, pitting edema. What can also occur, blood is backing up into the mesenteric, resulting in ascites. So we can see ascites in our patient. As it's backing up into the mesenteric and the hepatic veins, this can also result in an enlarged liver, hepatomegaly. It can also result in an enlarged spleen, splenomegaly. So when we think right-sided heart failure from a symptoms perspective, you're thinking system. So jugular venous distension, we're going to see edema, we're going to see ascites, hepatomegaly, splenomegaly are all manifestations that is quite common to see in someone with right-sided heart failure. So just to recap from our previous slide, right-sided heart failure, looking at the etiology, what are some of the things that can result in right-side heart failure? Left-sided heart failure being the most common. Cor pulmonale, which is right-sided heart failure secondary to lung disease. So think about that COPD patient with pulmonary hypertension. Right ventricular MI, so you have a heart attack or a myocardial infarction involving the right ventricle. It causes it to lose its contractility and therefore it cannot pump properly. And in valvular disease, so think again, between the right ventricle and the pulmonary artery is the pulmonic valve. And so that valve can become hardened or stiff, referring to pulmonic stenosis. Symptoms. So when we look at symptoms, we think about the right side of the heart failing. Everything is backing up into the system. So all of the systemic manifestations we can think about. So once blood back up from the right ventricle, it goes into the right atrium, then into venous systemic circulation. And so if it goes up into the superior vena cava or SVC, you're going to see jugular venous distension. If it backs up into the IVC or inferior vena cava, you're now going to see things like hepatomegaly, splenomegaly, ascites, and peripheral edema. Also to add here, because of all of the spacing or the third spacing and second spacing, you're going to see some significant weight gain in the patient with right-sided heart failure. So let's use this case study to bridge the gap of what we've covered so far. Mr. P presented to your ED with fatigue. On assessment, the patient was noted to have +3 bilateral pitting edema. The abdomen was distended with dullness noted in percussion, and the patient was also found to be presenting with jugular venous dissension. Chest with decreased air entry and expiratory wheezing. Past medical history of COPD, and he's a smoker for 15 years. Diagnosis in the emergency department was heart failure. So based on your assessment, which side of the heart is failing and what is the most likely primary cause for the heart failure? So if you start working through your presenting symptoms, the client is presenting with +3 pitting edema, which is, we know, as a result of backup on the right side. So this is right-sided failure. Abdomen was distended with dullness and percussion, and dullness is usually an indication of fluid. So we can safely say there is ascites, which again is right-sided failure. There is jugular venous distension because of backup into the superior vena cava, which again is right-sided failure. Chest with decreased air entry. This could be secondary to the diagnosis of COPD, which is chronic for this client. So based on the presenting complaint, we can say this client is experiencing right-sided heart failure. And what is the most likely contributing cause for that heart failure? Well, going back to our previous slide, we know COPD can cause right side ventricle to fail. Because of the COPD, it will cause pulmonary capillary vasoconstriction, causing increased afterload in the pulmonary system, resulting in pulmonary hypertension, which increases the resistance on the right ventricle, causing it to fail. So the most likely primary cause for this heart failure would be COPD. And if it is right ventricular failure secondary to COPD, that is referred to as cor pulmonale. Thank you for listening, and we will do part 2 where we look at the compensatory mechanisms that are involved with heart failure.